opacity here.
Yeah.
Can you see?
Yes, sir. Now I can see.
Okay. So it was a deceiving thing and you were stuck here. Just giving you feedback so that we
Yes,
don't
sir.
load it again.
Yeah. So I was actually worried about the left hilar enlargement, but I wasn't too sure because there was some rotation. So I thought that maybe I'm just
I
overthinking
love
it.
was
But
okay, but there was a
yeah,
retrocardiac mass. Opacity was
yes,
there.
sir.
It's X-ray.
Yes, sir.
Okay. And here, I don't know, you took a lot of time for aneurysm and this and that because of hemoptysis, probably. I'm assuming. So I
Yes,
think
sir.
here you disappointed me. But again, you gained the pace and you found this opacity. So once you found the opacity, you should have asked me the lung window. You didn't ask me the lung window at all.
Oh, yes,
So,
sir.
I mean, if you would have asked me lung window and MIP images, you could see there is any other nodule, but there is no other nodule. So the
Yes, sir.
mass region has got some irregular margins, and I don't see any other pulmonary nodules. It seems a neoplastic lesion, considering the age and history of the patient. I would see the abdomen and pelvis to see if there is any other metastasis in the abdomen. So,
Yes.
I mean, examiner would say that there is no metastasis. You would have said already about no lung nodules. By the same time, you ask about the bones, and examiner would not take much time, and he would say no abdominal abnormality, no bone abnormality. Then you would ask that I would send this patient for lung MDT discussion for potentially CT guided biopsy. That's it. Okay. If you would have seen some lymph nodes here and there, you could say that I could see the lymph nodes that is less than a centimeter, which in this neoplastic case, I'm unable to figure it out. It is indeterminate lymphadenopathy. So I would request PET CT scan to see the activity. So in this particular
Yes,
case,
sir.
PET CT scan was done and these lymph nodes were low activity, so considered as benign or rare.
Benign.
Okay,
Yes, sir.
so
Yes, sir.
just once you found the neoplastic lesion, you would say for staging the lymph nodes, other lobe involvement or other lung involvement that would go to M1, and hilar lymph nodes, you don't see any hilar lymph nodes, then mediastinal is very less likely if there is no hilar. Okay, so staging will be
Yes.
changed. This is contralateral mediastinum. So it is a neoplastic lesion, and that was a deceiving calcified granuloma. Is that okay?
Yes. Yes, sir.
Okay. So very quickly we'll go to some other case, maybe one or two, and then we will wind up. And I would give you some rapid reporting sort of things. Okay, and here we have one patient. Okay, 13 years old female pediatric age group presented with right lower limb pain.
Yes, sir. So I'm presented with an X-ray of the knee joint involving the l- distal middle third of the femur and the upper um, tibia. Um, she is suffering from pain. The most striking abnormality that I picked up is this periosteal reaction along the diaphysis involving the lower femur on both the sides. It is more striking on the medial aspect of the tibia, and it appears to be of aggressive nature. Um, I can see that there is a sclerotic area eccentrically involving the um, distal metaphysis of the tibia. If I would request you to, if you can kindly give me another orthogonal view to further characterize this and comment on the zone of transition. Um, Sir, can I window it a little bit because it's too bright?
I, I would do
Can't-
it. I would do it.
yes, sir. Yes, sir. Thank you so much, sir. So, uh, yes. So, um, I see that there is a very subtle lucency in the area of interest, which is surrounded by area of subtle sclerosis. Along with this, there is some periosteal reaction. There is the zone of transition appears to be wide, and there is, um, I don't see any obvious cortical um, destruction here on the X-ray, nor do I see any evidence of a fracture. Um, so, in a 13-year-old with an aggressive looking periosteal reaction, my first the disease that I would like to first and foremost rule out would be possibility of a sarcoma, and the because of the configuration of the periosteal reaction, which is rather uh, laminar in appearance, I'm concerned about Ewing sarcoma in this patient. And my second differential here would be osteomyelitis, and third would be Langerhans histiocytosis. I'll open up the patient's previous notes and look for possibility of raised inflammatory markers in this patient to rule out possibility of osteomyelitis, and I would uh, carry this case forward with an MRI of
Which sequence would you
the
like?
femur.
Which sequence would you like to have?
Sir, I think I'll go where the money is. So I think I want to look at the contrast enhanced, see the saturated image.
If I don't have,
Then I think a stir image would be very, very helpful, sir.
can you scroll?
Yes, sir. So so the lesion, okay. So there is a signal alteration in the lower shaft of femur with heterogeneous signals of mixed intensity, areas of low density intermixed with areas of high density marrow edema. But predominantly, I think that this is uh, looks like an osteoid matrix within the lesion with a well-defined extraosseous component which is extending into the adjacent muscles. These are the vasti. Uh, Along with this, there is some periosseous soft tissue edema. Uh, there, I wasn't able to pick up this kind of periosteal reaction on the X-ray, but now I think I would retract from my previous differentials, and I think that this is uh, looks like a case of osteosarcoma. This patient, I would like to look at look at the images in my routine practice. I will check out the axial planes and contrast enhanced uh, in order to look for neurovascular bundle invasion and oh, okay,
Axial.
yes, sir. सर कभी तो चलता नहीं है और कभी एकदम पता नहीं कहाँ पहुंच
अभी
जाता है
यहाँ से अब मेरी तरफ से probably loading में problem है. I'm sorry for that.
नहीं 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 सर आई थिंक ये मेरे माउस से शायद बहुत जल्दी हो जाता है. So, okay. So the neurovascular bundle appears to be, I mean, there is stranding around it, fluid stranding around it, but I don't see any obvious involvement of the neurovascular bundle. I shall put this in my report as well. And this patient will require a CT chest, abdomen, pelvis for staging purposes and would require histopathological evaluation after discussion in a sarcoma MDT, keeping the orthopedic surgeon on board who will decide about the resection margins, which will be included um, in the resection field. So there is minimum chance of seedling, and I think this patient will benefit after the histopathological evaluation. I think this patient will benefit with a referral to a dedicated tertiary care sarcoma center for further management.
Very good. So, very well done. I think we should close it. Are you people interested in this rapid reporting? I have one more case actually I wish to show you because this is very interesting case, but
Sir, दिखा दें. Yeah, please do.
running short of time. But then, okay, okay, okay. But last case ये दिखा रहा हूँ मैं उसके बाद देखते हैं if I would have energy then we will go for rapid reporting for I think participants would be waiting for that and I announced so it's my responsibility to fulfill. Okay, this is a patient, 75 years old female who has presented with dyspnea and desaturating. So, this is your last case, please. Yes,
Yes, sir.
candidate.
Yes, sir. You said dyspnea, and I'm presented with the CT scan axial slices of a 75-year-old female who's presented with shortness of breath, dyspnea, and um, she's desaturating. Um, I'm um, well, I don't see any obvious pathology within the visualized APCs of the lungs. Uh, can't look find any obvious bone lesions. There is, however, a left-sided um, pleural effusion. Actually, it's on both the sides, but it's more pronounced on the left side and extending along the fissures. Um, the effusion, okay, the left-sided effusion is associated with basal with the adjacent lung collapse, which is enhancing. And there is some volume loss on the left side as we're going down with the heart being shifted towards the left side. Um, there is also some basal collapse on the right side. Overall, um,
Sorry. Yes.
so the patient has bilateral pleural effusion, and that much I've picked up on the soft tissue window. Uh, sir, it's not working, sir.
Just try again, please.
Yes,
Please.
I'm trying. I want to go up back again to see uh, heart sizes slightly enlarged. There's no pericardial effusion, and there's a lot of subcutaneous tissue fat stranding, which is likely in keeping with generalized inner sarca. And haven't come across any lung mass till now. So, sir, can I have a look at the lung window, please?
There is nothing significant in that.
In the lung window. So, I guess that there is
Sorry, sorry, sorry,
bilateral.
sorry, 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 sorry.
Yes, sir.
Wait. Yes. Here we go, the lung window. Okay.
Oh, okay. Uh, okay. So there is a mosaic pattern of parenchymal attenuation in the visualized right-sided lung field and to some extent in the left-sided lung field. There is no interlobular septal thickening suggesting interstitial edema. There are no nodules. I don't see any obvious. Um, there's no pneumothorax. And sir, is in my routine practice, I'll go over the notes of the patient to know if the patient is febrile, and because uh, and also uh, uh, so overall there's bilateral pleural effusions with basal consolidations, hard side of upper normal limit. I think I haven't been able to get to a conclusion for this, but this can be either because of the increased hydrostatic pressure in this patient, because I can also witness some subcutaneous edema, and there's no obvious lung finding except for fissural thickening on the lung window. So I'll check for the I'll check with the renal status of this patient if she is has a
Sorry,
underlying
I
renal
mean, just
condition.
an input and just a friendly advice. I mean, I'm no more examiner now. आप क्यों नीचे नहीं ले जा रही पूरे स्कैम को नीचे क्यों नहीं ले जाती मुझे ये बताया
Sir,
मैंने
वो
वैसे से
sorry, sir.
मैंने सोचा कि मैं इतना जालिम ना बनूं मैंने कहा लंग विंडो दे देता है आप पूरा नीचे क्यों नहीं ले
Yes,
जाती
sir.
पूरे स्कैम को कंप्लीट क्यों नहीं करती आई मीन
Yes,
सॉफ्ट
yes, sir. So there's a pocket of free air
यस
um on the left side and the right side, and
यस
I'm so sorry, sir. Well, I'm just
आप यहाँ
maybe
तक आती हैं यहाँ तक आती हैं आप फिर ऊपर चले जाती हैं फिर यहाँ तक आती हैं आप ऊपर चले मैं देख रहा हूँ कि ये एयर है
sir,
ये बोले आप बोलें कब बोलें एनीवेज
I'm
जस्ट
so sorry.
कंक्लूडिंग दिस सॉरी क्योंकि रनिंग शॉर्ट
No,
ऑफ
no. Yes, yes,
है
yes. I'm so
ठीक है
sorry,
देखिए
sir.
अभी मैंने
So
ये केस
there's
आपका खत्म नहीं हुआ है ठीक है नीमो
that's right.
पेरिटोनियम ठीक
No
है
peritoneum wear.
है
Yes,
ना
sir.
अब
Yes.
आप जो है वो पल्मोनरी सीटीपीए में दे रहा हूँ आप पल्मोनरी एम्बोलिज्म पे कमेंट नहीं कर रही You should have commented. There is no pulmonary embolism. There is no right heart strain. I could see there is interventricular septum which is convex towards the right. So I mean,
Right side, sir.
जो आपने सीटीपीए का कमेंट नेगेटिव बोल देना है फिर आपने सोचना है आई मीन डिसेचुरेट कर रहा है लेफ्ट साइड पे फ्लूइड ज्यादा है यस यू आर वेरी राइट एक्चुअली यू समथिंग पॉप्ड अप इन योर माइंड के भाई इन्फेक्टिव मार्कर्स देख लें मैंने सोचा मैं लंग विंडो ना दूं आपको आप इसी में मुझे बता दें मैंने कहा यार थोड़ा सा हार्श
Mm.
हो जाएगा मैंने कहा थोड़ा जालिम हो जाओगे मैंने कहा चले लंग विंडो दे देता हूँ अब आप अगर इसमें ही नीचे जाएं तो देखें कुछ आपको ईयर पॉकेट्स यहाँ
Yes, sir.
आप
Yes,
कुछ
sir.
यहाँ पे देखें तो आपको कुछ नॉर्मल एयर बहुत सारी है पड़ी हुई ठीक है ना तो आपको फॉरन रेस करना चाहिए एंड यू शुड हैव आस्क्ड मी फॉर सीटी एब्डोमेन तो फिर मैं आपको
Yes,
सीटी
sir.
एब्डोमेन दे देता फिर मैं आपको सीटी एब्डोमेन देता तो आपका केस कंक्लूड होता आप कुछ ठीक है तो ये देखें आप पहले मैं ये दिखा दूं कितना फ्री एयर पड़ा है ठीक है और
Yes, sir.
लेफ्ट साइड इफ्यूजन भी ज्यादा है लेफ्ट साइड पे फ्री एयर भी ज्यादा है यहाँ पे तो फौरन सीटीपीए के बाद हमने फौरन पेशेंट को बुला के जो है हमने कहा कि इसका जो है और ये देखें सराउंड कहाँ कर रहा है देखें देख रही हैं आप कहीं सराउंड कर रहा है
Yes, sir.
ये जब फिर
Yes,
इसको
sir.
आते हैं वापस सॉफ्ट टिश्यू विंडो पे तो हम
Yes, sir.
कहते हैं, यार ये तो स्टमक है ठीक है
Yes,
ये
sir.
स्टमक है, तो फिर ये आगे फ्लूइड क्या पड़ा होगा? तो फिर ये
So
फ्लूइड
this there has been a
फिर आपने लाजमी परफोरेशन कहीं तो हुई है। फिर आप
yes
इस
sir perfect.
देखते हैं, आप देखते हैं यहाँ पे एक
There's
डिफेक्ट।
a defect. Yes sir.
आप कहते हैं इसका मतलब है गैस्ट्रिक परफोरेशन हो गई, फ्लूइड आगे भी चला
Yes
गया पीछे भी, और ये फ्लूइड को सराउंड कर रहा है एयर, ये स्टमक नहीं है, ये फ्लूइड है। ये देखें,
yes sir.
स्टमक के पीछे भी फ्लूइड है, स्टमक
Yes
के
sir.
आगे भी फ्लूइड है, और
Mhm.
ये पेरिटोनियम का केस था, स्टमक परफोरेशन था। ठीक है, CTPA पे आपने स्टमक परफोरेशन पकड़ लिया था। ओके, तो हम कंक्लूड करते हैं, यू पीपल आर सो गुड। आई एम नॉट श्योर के आई मीन आप सारे कैंडिडेट्स हैं मार्च या जून के।
Yes sir. March
वेरी
के sir.
वेरी वेल डन ऑल ऑफ यू। जो नहीं पता हो वो नहीं बोलना है, ज्यादा वहां तक बोलना है जहां तक नजर आए, जो नहीं पता है उसको खा जाना है। नेगेटिव फाइंडिंग्स
Yes.
बोलनी है, दैट इज वेरी रेलिवेंट, वेरी मच रेलिवेंट। और
Yes sir.
कोई क्वेश्चन, एनी क्वेश्चन, फिर हम रैपिड रिपोर्टिंग में क्विकली
सर
जाते
सर
हैं फिर।
मेरा सर मेरा मेरा एक क्वेश्चन है सर।
जी जी।
सर जो प्रॉब्लम हमें आजकल फेस हो रही है, खास तौर पे मुझे, आई आई कैन स्पीक फॉर माई सेल्फ हियर, वो ये कि जब हमें माउस से इमेज को कंट्रोल करना होता है सर, उसके अंदर बहुत कंफ्यूजन हो जाती है। आपका ध्यान उसको चलाने में होता है, बिकॉज जैसे आप चला रहे होते हो वैसे वो चल नहीं रहा होता है। कभी वो छलांग मार के आगे पर चला जाता है, कभी पीछे आ जाता है। तो क्या
वही।
ये एग्जाम में भी ऐसे ही होता है
नहीं नहीं
सर?
नहीं, बिल्कुल भी नहीं होता। इनफैक्ट मेरे वाइवा में जो है वो कर्सर रुक गया था, तो आपके साथ एक बैठी होती हैं या बैठे होते हैं, वो चूंकि चेक कर रहे
जी
होते हैं कि
सर।
आप झूठ तो नहीं बोल रहे, अभी तो आप तो सच कह रही हैं ऑफ कोर्स, लेकिन वो होते हैं, तो फिर वो एग्जामिनर को बताते हैं। फिर मुझे अलग से टाइम दिया, उन्होंने अलग से टाइम स्लॉट दिया कि इसका टाइम ज़ाया हो गया तो इसको और टाइम दे देते हैं। ठीक है,
अच्छा।
तो वहाँ
जी
हाँ
सर।
वो बिल्कुल बहुत अच्छा होता है वो। और हम तो शायद, और अच्छा केसेस इसी तरह के इस वजह से दिखाते हैं, देखिए जो मेरे अब समझ में आई साइंस, CTPA में
हम्म।
आपको गैस्ट्रिक परफोरेशन दिखा रहे हैं, CT ब्रेन जो दिखाया मैंने उसमें वो आपके हिडन एरियाज देख रहे हैं, आप रिवीलिंग एरियाज देख रहे हैं कि एक छोटा सा इंटरनल ऑडिटरी कैनाल का लीजन है। यानी वो क्या क्या चीजें चेक कर रहे हैं, आपकी सेफ्टी चेक कर रहे हैं, वो आपको एग्जामिनेशन कोई दिखा रहे हैं, लीजन कहीं और है, वो आपके कॉर्नर्स चेक कर रहे हैं, वो आपकी अप्रोच चेक कर रहे हैं। सारे केसेस मैंने मिक्स करके इसी वजह से दिए कि से फॉर एग्जांपल वो पीडियाट्रिक का जो था, वो मुझे नहीं पता, अभी प्रूवन नहीं हुआ है, वो सार्कोमा MDT में हमने भेज दिया उसे। वो
यस
अ,
सर।
वो लाजमी है विंग सार्कोमा या ऑस्टियोसार्कोमा, एक चीज आप उसमें भूल गई जो कि प्रोबेबली आपको बोलना चाहिए था, लेकिन एनीवेज एक दो चीजों से कोई नहीं कम होता। हाँ, ये डिस्क्लेमर पहले लगा दूं कि ये मेरी ऑब्जर्वेशन है, जो मैंने अपना दोस्त अहबाब से सर्वे करके मालूम किया कि अगर आपने केसेस में कोई मोर्टेलिटी नहीं कर दी तो आप फेल नहीं होंगे, यानी 5 आ जाएंगे, वरना आपने भले आपने 20 केसेस किए बहुत अच्छे किए, एक में आपने पेशेंट का सेफ्टी कॉम्प्रोमाइज हो गई तो आप 5.5 या 5 पे आ जाएंगे। और मुझे ऐसा फील होता है कि 5 वो जो पेशेंट मर गया, और 5.5 जिसमें आप कोई चीज मिस कर गए जिसकी वजह से मॉर्बिडिटी हो गई। तो ये डिस्क्लेमर के साथ कि मैं आई एम नॉट श्योर, लेकिन जिन जिन से मेरी बात हुई है मुझे ऐसा लगता है कि ऐसा होता है। ठीक है, जितने भी अच्छे केसेस कर लें, लेकिन इस पे कोई कॉम्प्रोमाइज नहीं होगा कि जो है वो आपने किसी पेशेंट के साथ कोई ज्यादती कर दी। यहाँ पे ये देखें फ्लूइड फ्लूइड लेवल था, ये मैं आई वाज एक्सपेक्टिंग कि आप मुझे
यस सर।
हेमरेजिक कंप्लेंट।
यस सर।
ठीक है।
यस सर।
अच्छा, हम सारे पार्टिसिपेंट्स जितने भी हैं यहाँ पे, वो अपनी अपनी डायग्नोसिस लिखेंगे, इन द एंड मैं की रिलीज कर दूंगा रैपिड रिपोर्टिंग के 10 केसेस, 10 मिनट्स फर्दर। इरफान, आर यू विद मी? आई एम नॉट श्योर को होस्ट।
सर आई थिंक उनका वो नेट का कोई इशू हो गया था,
अच्छा,
तो
को
वो
होस्ट
अब
है
नहीं
यहाँ पे कोई?
है।
हम
सर मैं हूँ।
प्रोसीड कर सकते हैं बिकॉज मोर देन 2 आवर्स हो रहे हैं।
आई
ओके,
थिंक
10 minutes for RR rapid reporting, that is a key to success um, in FRCR for me, मतलब मैं तो यही समझता हूँ। पहला दिन आरआर और लॉन्ग केसेस का अगर अच्छा चला गया आपका, तो इट मीन्स के यू हैव डन अ गुड जॉब एंड वाइवा कीप देयर। ठीक है, स्टार्टिंग फ्रॉम नाउ 1 मिनट ऑलमोस्ट ईच केस दूंगा, और फिर मैं केसेस चेंज करता जाऊंगा, फिर एंड में हम 5 मिनट्स में बिल्कुल वाइंड अप कर देंगे। तो क्या सारे पार्टिसिपेंट्स चैट बॉक्स पे चैट लिख सकते हैं?
यस सर।
लिख सकते हैं?
जी
आपने
बिल्कुल।
सबको अलाउ किया हुआ है?
जी जी बिल्कुल।
ओके, तो सारे पार्टिसिपेंट्स के लिए आई मीन, ताकि वो भी बेचारे सुन रहे हैं, उनको भी अपने जो है वो एक्सचेंज ऑफ का मौका मिल जाए यहाँ पे। ठीक है, तो वी आर स्टार्टिंग नाउ। और अपने पास इसमें चैट बॉक्स में भी लिखना है, अपने पास भी मार्क कर लीजिएगा, ताकि आपको पता हो कि आपने सही किया या गलत किया। थैंक यू कैंडिडेट फोर, सॉरी, यस, टाइम स्टार्ट्स नाउ। show you the AP view as well. I'll show you the lateral view as well. Okay, is a time for feedback, for rapid reporting. I would post key, just tally your answers, please. Just ignore the RR 7, 8, 9 because I have just intermingled the cases, and I'm going back from case number 10. Can you hear me?
Yes, sir.
Okay. 10, proximal phalanx, left middle finger fracture. I could see some of the chat. Someone has written metacarpal. Two, three things in rapid reporting. Just make your habit left middle finger, proximal phalanx, non-displaced fracture. I mean, according to your convenience. Okay. So you will not lose a mark. Left middle finger, proximal phalanx. Okay. Whether if you are missing the side, then probably you are gonna lose your marks. We are going back to case number 9 now. R5. R5. We could see here there is a fracture of fibula. This is left distal fibular fracture, which could be seen here very easily. And you would see some of the images in which you will find AP and lateral view. So don't worry. The rapid reporting trick, usually people saying don't overcall, and we don't understand what does it mean by means don't overcall. You can't understand. If you see something, there is an obvious thing. And someone wrote here, I wish to enlarge. And yes, this is a good technique. First, go through with this clearly and then try to enlarge. And then see each and every bone. See each and every bone. If you would like to change the gain, you could change the gain as well. This is the third step. This is my practice, which I was doing in my rapid reporting practice. So case number 8, that was so easy, very obvious anterior dislocation. So I won't go for that case. And the RR10, that was wrist. And someone wrote, I think, chauffeurs or something. That is again overcalling. There is nothing. Yes, if you wish to magnify, this is our fault that we can't magnify here. If there is some subtle lesion, then you would have an opportunity to magnify. But this is absolutely normal wrist. Going back to case number 6, that was RR3, and RR3 means this one, and view reports and load anonymized. Yes, supracondylar fracture with joint effusion or pad displacement, you could see here as well. You could magnify, right? So non-displaced supracondylar fracture. Most of the people got this answer right. And now, fortunately, I'm not sure, fortunately or unfortunately, but I have given you this image, which is, sorry. This case, I would have given you this only AP view, but I thought it's fair. Actually, it is on AP view, they could give you this one. If you magnify, there is a non-displaced fracture of head, but it was also obvious here. And this is a typical exam. So radial head fracture. Going back, yes, it was a wonderful pickup. Few people have picked it up, and again, this is really this is exam case for sure. There is no doubt about that. Absolutely normal, absolutely normal, absolutely normal. Yes, here, there is a fracture. I should have given you this one as well, but I don't think they will give. Some cases are settled, so that's why I'm just planning myself that how my exam uh, went. So there is a medial one third right clavicle fracture. Other cases which is more tricky, in which I have given you the normal cases, that is more tricky. So I could see many people tried to make something. Please, please, please don't try to make anything out of it. Absolutely normal. That is most difficult in rapid reporting because you don't see um, such as ambiguous cases in which you are saying coarctation, someone not saying, you are saying left lower lobe collapse, other radiologist saying no, no, I don't agree. Absolutely crystal clear abnormality which 10 radiologists could see, that would be an abnormality. Yes, there is a chance that if you are missing, should be right displaced and non-displaced. Not really, not really, not really. Good question, not really. Even if you are saying fracture, site and area and good anatomy would be sufficient enough. So this is normal, absolutely normal. And then RR8 and 7. I would appreciate if you people would give me the feedback for this session, and that is almost 2:30. What was that case? Sorry, it was case number 8. Any query, please write down on your chat box. So I would address. Absolutely normal, absolutely normal from everywhere, and I could see that mostly people have written the normal. So this is normal X-ray. And lastly, RR7, that was again chest, and that was again normal. Chest is most tricky, and if it is normal, then definitely it is. So, absolutely normal. And yes, one of the chat box demonstrating that normal variation right hump, no need to write. Normal means normal. You don't have any option to write down in your normal slot. If you will write down abnormal, then you have a chance to write down. So normal means normal. That's
Sir,
all. Yes, please, please.
सर ये right pericardiac छोटी सी opacity, could this be a consolidation? इस तरह का
Good
अगर
pick
हो
actually.
scenario.
Good pick actually, but yes, I think my apologies for that. But I could show you another case of this patient in 2013. So
Okay,
yes, I think you are absolutely right. I should not have given you that case, but that
yes,
is normal actually,
yes,
unfortunately.
sir. Yes,
So good pickup, by the way. I mean, I should
thank you.
exclude it from my list probably. Yes, and someone asking for feedback. Won't you mind to send the feedback form here for? And if anybody has any question, please write down. I'm just keeping it open and I'm just muting myself